we always have this myth of the people who have a lot who are actually really sad. But this is not that. This is the person that actually even thinks that they're fine.
Hmm.
Like they're not walking around hiding their sadness. They think they're fine. Like they're in such a state of like denial, right? Like, no, I'm fine. What do you mean I'm depressed? Welcome to today's episode of the Medical Disruptor, the show where we challenge outdated medical norms and redefine what true wellness looks like. I bring you the innovators, the boundary breakers, and the trailblazers who refuse to accept the status quo. These disruptors are revolutionizing the way we approach wellness. On today's episode, we meet Dr. Judith Joseph. Everyone calls her Dr. Judith. She is a cutting edge psychiatrist who's redefining mental health by talking about something called high functioning depression. It's a condition that affects millions, but no one's really talking about it. She just finished the first ever study on HFD, high functioning depression. It's literally the first and only study on this topic. If you go to PubMed and search it, she's the only one who shows up. I was blown away. I learned so much. Let's dive in. Welcome, Dr. Judith. I'm so excited to have you here.
I'm so excited to be here. Thanks for having me.
Of course. Now, if you guys don't already know who Dr. Judith is, first of all, where have you been? Okay, so look her up ASAP. But second, we're going to be talking about a really cool concept that we have not touched on. We couldn't touch on it because Dr. Judith pretty much invented the concept. But before we get there, Dr. Judith, tell us a little bit about your schooling, and which I imagine was kind of conventional, and that something must have happened for you to be like, I want to explore this topic. Tell us a little bit about that shift.
Yeah, well, high functioning depression, I wish I could take credit for it. The term started emerging in basically the internet in like the early, or maybe like the around the 2010s, 2015 era. So like you can actually search for terms to see when they were invented.
Fair.
So people were using it before me, but I was the first one to really put it on the map in terms of a psychiatrist validating it, saying it's real, and saying that it was not just pop culture.
Mm-hmm.
And I run a research lab in Midtown Manhattan, and I just published the first ever peer-reviewed clinical research study on high functioning depression in the world. We enrolled about 120 patients and did like these rating scales and tried to understand what it was about these patients where they had these symptoms of depression, but they were still over functioning. And so that was just published recently. You can search it on PubMed. It's literally the only article in PubMed on high functioning depression.
I
So
love
it's
it.
kind of cool, you know?
That's really cool. And I can't wait to dig into the concept itself. Well, what made you decide to go down this road? Like, what brought you here?
Well, initially, I was actually an anesthesiologist. When I went to med school at Columbia and I
Mm,
graduated, everyone graduates with a medical degree and then you can go into residency. I ended up going into anesthesiology because at the time it was like high paying, prestigious, competitive. And I was myself checking the boxes and being pathologically productive and doing what my parents said to do. And then I found myself in like this existential crisis where I was like literally under the operating room table one day. I remember the day I was like opening up the Foley and like measuring the urine. And I'm like, why am I under this cold table with the urine in my face? Like, I was just like,
that,
this is not fulfilling. I don't care how prestigious or how much it pays. I don't want to do this for the rest of my life. And not to knock anesthesiologists. I think it's a important field. They deal with so much uncertainty every day. People just think, oh, you put people to sleep. No,
mm,
like you're
mm,
literally keeping them alive while a surgeon is cutting them open and killing them, literally. So it is a very stressful field. That's why they get paid more than the surgeons. They also have one of the highest malpractice rates because literally a life is in your hand. So either I would describe it as being 90% boring, like you're just waiting for the surgery to be over, and then 10% sheer terror because you're trying to save a life.
I
And I'm
love this
I'm
description of anesthesiologist.
right. And I'm like a very anxious person. So like I would be like the one perseverating on that 10%. Like, when is the person gonna die? Like, so I would get really bad panic attacks. And like I remember going to someone in the program and saying, I don't think this is for me. And they said to me, everybody is depressed. Like,
Oh,
that's just a part of medicine. And I'm like, oh, okay.
oh,
And I
okay.
was just like, oh, I didn't
Wow.
learn that in medical school. So maybe like this isn't for me. Cause like I'm not okay with that status quo. And I ended up leaving, but being very fortunate because there was one spot open at Columbia for psychiatry and a bunch of like surgeons, surgical residents, internal medicine residents were trying to like vie for that one spot, but I was the only one out of all of them who knew how to do A lines. That's like the arterial line.
Yes.
And one of the top researchers at Columbia Psych was doing this study where she needed A lines to be put in. So they were like, oh my gosh, we have like a psychiatrist who could do A lines. And I got the spot. I beat out the surgeons. So I was
I
like,
love
wow.
that so much. That's such a random skill to get you into psych residency. Like
Right?
that's like
Like
doesn't
so
even
random.
compute. It's so random.
So I got
Wow.
to stick it to the surgeons because, there's a long-standing beef between the anesthesiologists and the surgeons. Like people in
Absolutely.
medicine, they know it. They understand
There's
that
like
very well.
there's certain turf wars like ICU and ER, also another turf war. Like there's just that's so funny. Nephrology, cardiology. Yeah.
Mhm.
That's hysterical. Wow. So A line gets you in. That's amazing. Well, that just shows it was meant to be.
It
'Cause
was in
it's
the stars. Because can
yeah,
I
it's in
tell
the
you something?
stars.
I've never told anyone this, but I did not even one A line in all of my residency at psych and, anesthesia. I did a ton, but like they ended up not being able to use my skills because technically they were like, wait, but she's a resident in psych now. So like the malpractice won't cover her
Oh
for
my
that. And I was
God, that's
like,
hysterical.
well, I got it too late.
That is so funny. That's a great story. I mean, that is such a universe intervening.
Yeah.
Oh my God. Okay, so you go into psych, but you're still not
Mhm.
thinking about depression yet, right? You're just you gotta
Yeah, actually at Columbia Psych, they allow the residents to get this like very top-notch reflective psychodynamic psychotherapy with some of the best psychoanalytic psychiatrists in the world because like New York
wow.
City has so many of them, you know that, right?
Sure.
And so like I remember when they were offering us the sessions, they were like, you just have to pay. Like technically they would have done it free, but because of the nature of therapy, you're supposed to pay. There's something about paying that keeps you responsible and you
Yes.
analyze the whole pay structure. That in itself, psychoanalysts analyze when you're late for a payment or you underpay, you overpay. Like, it's a part of the game, right?
Yes.
Like, so like we had to pay, but it was something little, like anywhere between 25 to $50 per session, which is like, you know, like really cheap because
Yeah,
at the time the regular person was paying 5 to 600 for those sessions because psychotherapy is very expensive, right?
absolutely.
So we were getting it at a steal. And I remember being like, I don't need therapy because I had never been in therapy. In my mind, I thought, psychiatry was for people who are very mentally ill, like
Sure.
severe mental illness,
You're a high
bipolar, schizophrenia.
performer.
Right. I was like, I don't need that. That's wasting valuable resources. And they were like, well, it is highly recommended that everyone does their reflective work. So I was like, fine, I'll just do it. And I just remember being like, oh my God, like I thought I was fine, but I am traumatized. I thought I had no trauma. Like, what?
I'm laughing because I feel like that's always the beginning of the story. Like, I don't need this. Insert X here. And
Yeah.
then you're like, oh, I'm the poster child for this.
Yeah.
That's hysterical. Okay.
So therapy was for me like so eye opening. I talk a lot about it in my book how people like me who are high functioning AF, we think that we have it all figured out, but
Yes.
we're just pathologically productive. We busy ourselves to
Love that
distract from
term.
pain, trauma. That's our avoidance.
I
So
love that term, pathological performance. Is that
pathologically
productive for
productive.
all performance? Yeah, pathological. I love that. I've only recently realized I was doing the same thing. It's the ultimate escapism, and no
Mhm.
one will tell you to stop.
No, it actually benefits capitalism. It benefits your boss. It benefits everyone but you, right? Like, so
100%.
no one calls you out. No one says, oh, we got to like work on your joy. They're like,
Yeah.
no, I'm benefiting from you being busy and running yourself ragged because you're giving and I'm getting, right?
Yeah. No one's gonna say, "Let's slow down." No one's gonna say
No.
that.
Mm.
Let's not get A's. Let's not make more money. Let's not
Yes.
open up another business. Wow. So interesting. Okay, so that's when you already started realizing, like, but were you able to stop? Were you able to slow
I
down?
wasn't. I
No.
wasn't. And like my therapist, he would say, like, I remember he called me this word. He said, you're a masochist. And I thought, and I said to him, I said, but we just learned in our DSM-5 class, that's no longer a word. He goes, oh yeah, it's not technically in there, but we still use it. So I was like, what? So then, you learn about all these things that psychiatrists still use, but like
I
you're
love
not
this.
allowed to talk about. So I
Yes.
put all this in my book because I'm like, we need to democratize mental health. Like, why is it this big secret? But he told me that I tended to bend over backwards. And the reason that masochism was taken out of the DSM was because it was being incorrectly used to label people who are victims of or survivors of domestic violence, right? So like you're inciting violence on you. So you're doing
Oh,
things to provoke someone,
oh,
right?
like blaming the victim.
Blaming, victim blaming. So, but there are elements of masochism that actually are appropriate, right? Like, so like you don't want to get away, throw that away. The parts that have to do with people pleasing, the parts that have to do with self sabotage. So yes, we want to like clean up the diagnosis a bit because it was problematic, but we shouldn't have gotten rid of it because there are many of us who do things like taking on that extra shift at work,
Yep.
doing the favor for the parent who never returns the favor,
Yep.
helping out family members who are not grateful, right? We bend over backwards because we're raised to be the good girl, the big sibling, right? The people pleaser who gets rewarded, taking on more work when they're not even getting a raise, right? So
Yeah.
things like that are really part of the course of someone with high functioning depression.
And do you think that this affects women more and then women of color more?
I do. I think women, by definition, we know this. There's not a lot of data on high functioning depression because I'm the only one who did the study, but we know that there's a lot of data on depression, right? And anxiety. Women are twice as likely to have depression and anxiety than men. And like that to me is like, whoa, why aren't we like screaming this from the rooftop? Like, but again, it benefits society for us to be oppressed. And like, women of color in particular go through so much more trauma. Like the rates of PTSD are so much higher in the Black community. The rates of postpartum depression are higher in the Black community. The lack of access is higher. Not just Black women, it's women of color because we are often told that we are lucky to be where we are. Like forget
Yes.
if you have good grades, if you worked hard, like you're just treated as if you don't belong. And so what do? If you're struggling, you don't want to say, I need help because that perpetuates a stereotype that you're not even worthy. So, like, I think that, women and women of color in particular are at high risk for high functioning depression because we are rewarded and punished, right? We're rewarded for being pathologically productive and punished if we're not.
100%. That's amazing. So we're saying there's like an obvious, I just want to re-say it, right? Correlation between this characteristic of people pleasing
Mhm.
and this high functioning depression.
Mhm.
So any category, not that everyone with people pleasing has a functioning depression, but
Right.
much more likely.
Yes.
And it's interesting because the high functioning piece is because they're such people pleasers, they're going to be high functioning.
Mhm.
Oh my God. And it masks this whole thing. Meanwhile, they're walking around depressed. So what does the depressed piece feel like? So we can understand what the high functioning looks like. And we certainly see, and what's the mantra, right? Like women have to work twice as hard and
Mhm.
women of color have to work. If women have to work twice as hard, then women of color have to work, whatever. Like there's this like constant understanding that, sometimes if I look at someone, in a certain position and it's a woman of color, I'm like, this woman has to be like 50 times smarter than
Yeah.
every white
Yeah.
person in that room
Yeah.
because to get to where it's like, we know what the high functioning part looks like. What does the depression piece look like?
You know, interestingly, forget the subgroups, forget the immigrant, forget the healthcare provider, the nurse, all the people, the teacher who they're all at risk because they have to push through pain and they're undervalued. But when you look at trauma and depression, we know trauma is closely tied to depression. People who don't process their trauma, they internalize guilt and shame and blame. They have the cognitive symptoms of depression. But so I wanna, that up too, like unprocessed trauma. And, when we use trauma a lot and people get really annoyed, it's like, oh, everyone has trauma. But there are levels of trauma that we are not allowed to acknowledge. And it's important to acknowledge it, right? Like if you're treated poorly because of how you identify, because of who you love, because of where you came from, because, you're an outsider, so to speak, that's trauma in itself because you are constantly having that at the back of your mind that like, I don't belong here. I gotta watch my P's and Q's. But
100%.
then there are the larger traumas, right? Like, things like leaving a country during a war and fleeing, leaving a country that was overrun with, like, criminals and fleeing. A lot of immigrants in this country did not come here out of, like, the best circumstances.
Yeah.
They came here to save their lives, and they don't get to process their trauma because they're told even within their own communities that like, well, you're lucky to be alive and you're lucky to
Right.
be here,
Keep
right? So you
going.
have to take every opportunity. You can't slow down, right? And then, so those are unprocessed traumas that don't really get highlighted. Like if you tell your doctor, like, oh yeah, I came from this country when I was a kid, they'll be like, okay. And what's going on now? They won't like be like, oh,
No,
well, what was that like? You know?
you're not allowed to talk about the past. The HPI is
No.
right now. Well, why did you come today?
Right.
The HPI is today. That is so funny. We talk about functional medicine all the time. Go ahead, sip your tea. And in functional medicine, we start like at birth, but in conventional medicine, it's like that nothing to do with this. Not this like it doesn't fit the HPI. But
Hmm.
you know, before we go, I want to say something about that first part that you said, right? Of course, levels of trauma, that part of living with having to like watch your P's and Q's. Obviously someone from the rainbow community, once a year we go to a town, it's called P Town, where everyone's gay. And as soon as I get there, the first time it happened, I was surprised by it. As soon as I get there, I exhale. And the first time it happened, I didn't realize how much I was holding my breath the whole time. Now I really look forward to it because I know that's happening, but I don't even recognize that all day long, all the time. I'm watching my P's and Q's and never consider that as a form of trauma. I was like, okay, that's just the world of being there, and this is the world being. And I think there's, people of color will say, when they're like in their communities and they feel like they can express themselves a certain way, like you don't ever realize how much you're not just not being yourself when you're presenting in whatever this world is. So that's really interesting that you said that. I would never have classified that as trauma. So thank you for bringing that up. Then you have all these
And
traumas and
I actually
yeah,
included that in my trauma inventory because when people don't process their trauma because they're busying themselves, right? Like how you didn't recognize that was a trauma, sometimes they'll never acknowledge it. So I actually modified the Kaiser and the Philadelphia ACEs to include questions like that. Like, were you as a child, were you excluded because of how you looked, your race, your cultural beliefs, or how you loved, right? And I put that in childhood and adulthood because I want people to like bring that to the surface like,
wow.
wait, like that actually was like painful because we're social creatures. If we feel rejected, it like literally feels as if we're physically hurt. When you light up the brain,
Yeah.
social rejection looks like physical pain. So like I
Wow.
want people to like acknowledge that like this was painful for you and you just pushed through. You didn't even acknowledge it. You just went ahead and got those A's. You went ahead and graduated. You went ahead and became a full adult. All your life, you never even acknowledged that trauma that was literally weighing on you every single day. Like that, and that could be so powerful.
That's so amazing. But what does processing trauma mean?
So it means acknowledging that it happened to you, right? Accepting it, acknowledging and accepting it. Because when you busy yourself, it's almost like you're telling yourself it didn't happen. So you're gaslighting yourself, or it wasn't so bad, or other people went through it too. Yeah, other people maybe went through it, and maybe for some it wasn't so bad, but it was still bad. Like
Yes.
it still happened.
Yes.
And when you reframe it that way, then you stop internalizing shame. I've been doing PTSD studies for so many years, and like carrying out these studies as a principal investigator, I didn't realize until doing this research there were like 40 symptoms of trauma, right? And under one of those buckets in this standardized test that's usually done at the VA, but we pulled it into clinical research because it's the gold standard. It's called the CAPS-5. There's a whole section devoted to internalizing shame, blame, and guilt.
Mm,
So when you frame trauma as it wasn't so bad, it happens to everyone, you carry that guilt with you versus acknowledging that it shouldn't have happened to you. You didn't deserve it. And then you can start to let go of it. You don't have to work so hard to seem perfect, to seem put together because you're like, no, that shouldn't have happened to me. Like, I deserve to be treated with dignity. I deserve to be accepted and respected. Right. So it creates this huge shift. And like, it sounds very simple and granola but when that light happens, then you start behaving differently. You're not like, "Oh, yeah, I'll take on that project." You're like, "No, I did that project last week and I'm tired,"
I'm
Like
tired. It's so interesting that you say like being allowed to say I'm tired and like
Mhm,
just yeah, that is so interesting. Okay, so processing it. So we have this people pleasers
mhm,
who don't even recognize that they have trauma, who have not processed their trauma, who are depressed, but they don't know that they're depressed.
mhm.
So what are
Busying themselves.
so their
They're
depression looks
busy.
with busying themselves?
Yes, they distract from pain. They people please, and they have anhedonia, which is a thing
Mm,
that is very prominent in the medical profession, but most people have never heard of it. And I'm really trying to change that because, again, I do so much research and I'm like, everybody should know this. Why are we like, we're all in like silos in our research labs, but it's like this stuff benefits other people, right? So I started talking a lot about anhedonia, which I call the joy thief. It like
Yeah.
literally means that the things that used to light you up just don't anymore. So like your food, you're not as into it. You listen to music, you're not dancing. You're just like, oh, it's like noise. You turn it off. You're reading your book and you're like, you put it down because you're too distracted with other things. So it's literally sucking the joy out of life. And a lot of people who are pathologically productive folks with high functioning depression, they won't look sad or distraught, but what they will have is anhedonia, which is like a meh or blah kind of feeling that
Yeah.
as society we've kind of accepted to be the norm.
Yes. Yes.
But it's not the norm. We were built with the DNA for dopamine for a reason. We're built to go out and move and to feel good when we went fishing, to feel a sense of satisfaction and accomplishment when we like gather, agriculture and things like that. So, you know, the way that our society is set up now to reward the pathologically productive, sedentary person who doesn't feel like as if they're worthy enough to really go out and get joy, we are literally in the space and time for the most anhedonia. And that, in addition to like all of the technology, which has completely rewired our brains
Yeah.
to
Just
receive
false
dopamine.
dopamine, right?
Yes, all
Mm.
of that. It's made us so numb because now we don't even access joy in the way that nature intended us to. We're not using our full senses or our bodies. We're getting it in a very basic, like two-dimensional way, and we're not living. And I call it we're humans doing instead of human beings because we're so busy with this, with a phone.
So
We're
true.
busy with the work. We're busy with everything else but being a human. And so anhedonia, masochism, and trauma are the three things that I see a lot in people with high functioning depression.
This is really, as you know, like groundbreaking information to really take a look at the most high functioning people around you and to think that they might be depressed, right? Because they have the fancy house and the great, you know, let me take a step back. We always have this myth of the people who have a lot who are actually really sad. There's that myth. We already know that myth. But this is not that. This is the person that actually even thinks that they're fine. Like
Mhm.
they're not walking around hiding their sadness. They think they're fine. Like they're in such a state of like denial, right? Like, no, I'm fine. What do you mean I'm depressed? I'm fine.
They know
Uh,
something's off. They just know it. They know something's off. They just don't know what it is.
You just don't know what
And
it is.
because they're so busy, no one checks in. And like if you ask them how you're doing, they'll say, I'm fine because they
Fine.
don't feel worthy enough to complain. Other people have bigger problems, right?
Yes. Right.
So
First world
yeah.
problems. I can't complain about
Mhm.
this. Yes, exactly right. Oh, that's so true. And then I would say, I mean, from my perspective, women in 40s, 50s, and 60s, if you add to that the mix of hormones,
Mhm.
right? So we have this underlying, and now we've taken away some of the hormones that kind of keep you together.
Mhm.
It's just a mess.
It is, and that's why I use the biopsychosocial in my book because, I use this saying from my lab. I say, understand the science of your happiness because there will only ever be one you in the future of the universe and in the past of the universe and in the present, only one you. So why are you applying tools to yourself that work for others when you don't even understand the science of your happiness? So when I
Hmm.
give this talk to women, I say like, okay, biopsychosocial. Biologically, you have these hormones that are different, and understanding how those hormones changes over time will allow you to prepare for the best for the future, right? If you're someone who had like, PMDD, premenstrual dysphoric disorder, had rough periods where you were very moody and exhausted, and then if you're someone who had postpartum depression, you're probably going to be more vulnerable in perimenopause and menopause. So you want to start planning in your 30s. And when I said that at a talk last week for 300 women, and they were like, "What, 30s?" And I said, "Yes, no
Yes.
one tells you that
Yes.
perimenopause starts in your 30s. That's why you're like, 'Oh, I'm so old, I can't party anymore.' No, that's perimenopause."
Yes. Yes.
That's why the belly fat is not as easy.
Yeah.
That's why you can't, like, eat 10 chocolate chip cookies like you used to.
It's so true. It's so funny that like we used to think, I mean, at least I used to think a million years ago, I was taught that perimenopause was like the year leading up to it, right? Like,
Yeah.
Now, I'm like, what are you talking about? It's like a minimum of 10 years before. And since you have no idea when your before is, like it's a retroactive study, you got to just assume that if you're feeling off, it's starting. And
Yep,
there's so many
it's the
options
truth.
now. Yeah. And
So true.
oh my God.
It's, like, unfair, right? Like, women's health has been just completely neglected in the area of
Completely
hormones.
neglected. At this
I didn't
point,
learn it in medical school. I don't
I
know
didn't
if
learn this. I did
no,
not learn this.
no worries.
I was going to say, luckily for me, I also have like this functional medicine piece, which I only acquired again later in my career because who studies that? But yeah, to your point with women's health, it's like sometimes I spend half the day because I don't manage hormones, but spend half the day talking to the women in my primary care practice. And I'm like, if your GYN's not giving you hormones, find a new GYN. Your life
Yeah.
will be different. Like it's so important. But now I feel like everybody needs this book.
Mm.
Like all my high functioning patients would be like, I feel like I need to read this book.
Listen, we're all there. If you're in medicine, if you're a therapist, if you take care of patients all day, we are like in our industry, we are ingrained like with that, put others first. So by definition, we're rewarded for being people pleasing and pathologically
Oh my
productive,
God,
right?
you're so right. So now it's like not only just women or women from a marginalized community, now we added the profession,
Yes.
which is of service.
Yes, caregivers. In my study, people who are caregivers had the highest rates of anhedonia, the highest, right? Well, and it makes sense because like you are taking care of everyone. You feel guilty if you say no because everyone
100%.
needs you. So of course you're going to exceed performance when you feel like crap. That's the definition of high functioning depression, right?
Yeah. So what does it mean when people say burnout in your world?
So burnout is occupational. So when the WHO first classified it, it was and it still is. It was I think it was in the 80s it first started going and they officially changed it and moved it to the 90s. But within that construct, it's when you're in a workplace setting. You are irritable, you're
Mhm.
exhausted, you don't enjoy the work anymore. But technically, if you're removed from that setting, you should be okay, right? Like, so the work is the problem. You stop functioning, right? Whereas with high functioning depression, it doesn't have to be at work. You're going through this anhedonia, even if you're not at work and you're over functioning, right? You're like coping with how you feel by overperforming. So even if you feel like crap and exhausted, you're taking on more projects. You can't say no. You're pushing through it. But eventually something's going to give. Either your body will break down. And I saw so many cases like that when I was in training. And now I look back, I'm like, oh, that was like their body broke down because of their what was happening
Mm,
psychologically. So
mm.
with their mouths, they would say, "I'm fine, nothing's wrong, I'm not depressed," but their body was like screaming for help,
Yeah.
Or those that like cope with drinking excessively. We all know those people or our friends or colleagues who like are aces when it comes to their work, but they're like hitting the bar heavy,
Yep.
or like smoking excessive cannabis. Like people use substances excessively. And also these phones are new substance. A lot of people are
100%.
so addicted to phones and to shopping online and all these things. So, there are other ways that it manifests, but it can also lead to actual clinical depression where you do eventually break down and you may, become so hopeless. And we've heard of those cases where very famous people who unfortunately died by suicide struggle with high functioning depression. We've heard of those performers who, they can't show that they're sad. They go on
Yes.
stage, they light up the room, but then they went and they died by suicide, right? Like it can become a clinical depression as well.
It's so interesting. So you're saying then that kind of the difference between burnout is that it's very much occupational. So the idea would be if we're accepting this, I don't know if I'm accepting this definition, but if I were going to accept this definition, that once you change your job or leave your job, you should be fine. Sit well for you?
Well, I think so because a lot of people get burnt out by corporations that are just flat out greedy.
And
And I know so many people were in these grinding industries, especially in entertainment industries where, if you don't work hard, if you don't stay out late, if you don't, mingle, you're not going to get the client, right? And then
right.
people are like, they have this breaking point where they're like, I cannot live like this anymore. And they take a less glamorous job and they're like back to,
They're back
living a
to,
good life, right?
yeah. Okay. That's fair.
But the
That's
person who has high functioning depression, they're taking that with them everywhere. They don't know how to slow down. They become you put them in, like, the easiest corporation, and they'll still overwork because 'cause they're running from something. They're
oh, I see.
running from
Okay. All
something.
right. That's a great distinction. Thank you for that clarification. So they're like this all the time. Like they're going to, even if they're not working, they're doing it at the PTA.
Oh my gosh, they're the ones who are on the weekends going through their emails. They're staying up at they don't spend time with their kid, but they're, like, doom scrolling at night, you know? They're the ones who can't relax on weekends. If they sit still, they feel empty and restless. They're busy cleaning or, like, doing some other busy activity,
So
right?
interesting.
There's
What
something that
about,
they're not processing.
it's so interesting because I would say too, like sometimes some of the things you're saying would describe me, and I'm bringing myself up for a reason, not asking you to analyze me. But then sometimes I really would tell you that I get pleasure from my work. Recently, I made a decision to slow down, but that answer, but I really enjoy what I'm doing. Is that a delineating factor in any way? Or is that like, is that what they would say regardless that they're getting joy out of it?
They would say that they enjoy it because but then you ask, "What is it that you enjoy?" Right?
Okay.
And a lot of times it's the actual getting something done. It's that
Okay.
feeling as if they accomplished something versus, spending time engaging in things that human beings should be doing, like, spending time with loved ones, resting,
Yes.
eating your food and, like, not looking at a screen and actually
Yes. And
tasting and chewing
chewing.
your food, right?
Chewing is a big deal. Yeah.
No, but some people actually 100% do enjoy their work, and when it's high functioning depression, some of that joy starts to get taken out of the work. They're no longer enjoying it as much.
Okay. That's it. That's well, sure, because anhedonia. So whatever,
Correct.
they're not enjoying that either.
Yeah.
No, it's an important delineation because I do think some people actually enjoy what they do it for others. And I think this is a fine line. That's why I'm spending time because I think to be a success in most industries, you do have to work more than average.
Mhm.
And so, and I do think that some people do enjoy that to be a, you can't just do like a typical 40-hour week and expect to get to certain, and I think in any industry.
It's not about being a hard worker, and it's not about, you know, putting more time in, but it's about over productivity to the point where you're robbing yourself of joy,
Yes.
right?
Okay. That's a really
And
important distinction because I
yeah.
don't want anyone who's like out there like, oh man, I've been working like crazy. Why have high functioning depression? So, like in both ways, I want some people to question themselves, but I also don't want everyone to be like, "Oh my god, I must have this." And if you're feeling joy, right, and happiness, then maybe you're not there yet. You might just
And also in my book, I talk about this. There are some people who have no choice. They have kids, but they're a single parent, work
mm,
hard, they have to pay the bills. It's not about like, okay, when you stop working, everything will be okay, because that is a myth, right?
yes,
And remember I said the difference between burnout and HFD is the burnout is caused by the work, right? But the HFD is gonna be there no matter what the situation, right? So, like, it's about finding
yes,
points of joy in spite of what's happening in life, and in my research lab, when people come in, they wanna be happy. They say, I wanna be happy." But in research, we don't use that word happy. We use words that describe points of joy, like if you're hungry, feeling satisfied, if you're tired, feeling rested, if you're thirsty, feeling quenched, if you're lonely, feeling connected,
interesting.
right? These are all points of joy. So it's a reframe. It's not like, oh, we're going to make you happy, because if you think happiness is an idea, joy
Yeah,
is an experience. So I want people to start tapping into experiencing joy no matter what in life, right? Because there are places in the world where there's war, famine, disease, and little children and people can still find joy, right? So it's not
yes.
about solving all
Uh,
your problems and being happy. It's about cultivating points of joy every
you
day.
said so much right now. You said so much. Oh my god, you said so much because oh, thank you so much for surfacing all that. This is why some people who then retire are still not happy because it's not work related, right? This is exactly
Yes.
it. Unlike the burnout, now I'm appreciating that distinction even more. Thank you. And so I love that so much. And then also this idea of this happiness, especially those are like, when I get this, I'll be happy. But
Mhm.
there is no constant state of happiness. It is really about finding the moments of joy and finding and in collecting them. That is a really important point because there's also perspective in there, right? There's
Mhm.
perspective. Like, I guess that's the next question. Is it just a mindset shift? Do we need medication if we're high functioning? Is it like, what is it in finding these joys? Because the joy is there, right? I was hungry, now I ate. It's there. Me being joyful from it, it requires some sort of shift. So how do we get that shift?
Yeah, some people will need medicine for based on your background, right? That's why I said understand the biopsychosocial. So biologically, if you have a history of major depressive disorder and now you have symptoms and you're over functioning, but you're not, having the low functioning or the significant distress that's required for the DSM-5 checkbox, your doctor might say, well, given your history of depression, maybe I will give you that added support. Or if you're someone who has a history of ADHD and, like thinking about the biopsychosocial, like when you are more supported in terms of being able to like focus, you're less depressed because you feel less overwhelmed and less stressed. Medication may be beneficial for you, but it's a case by case basis. If you're someone who has a history of trauma, the psychological part, and you're constantly in fight or flight or triggered, you're someone who may need the added support of a medicine or like a trauma therapy, right? If you're someone who has an autoimmune condition and the autoimmune condition causes you a lot of pain and discomfort and spasms, you may need that support, but not everyone needs medication. That's why I understand the science of your happiness is so important. For some, it's more about the social stuff, right? It's like, well, I live in a place that's cold and dark and I don't get a lot of movement. Well, then that's probably contributing to your depression, right? Or psychologically, if you have an attachment style that's avoidant and you feel very lonely because it's hard for you to keep relationships in the mix, then you need help support there. So everyone's so different. And that's why it's not like when you think about mental health, it's not like one size fits all. You can't just watch a meme or hear a podcast and then like save your life. You got to really think about the science of your happiness and support yourself based on that.
I'm laughing because it's like, you mean it's not just the GAD-7 and then prescribe it, bro? It's not that simple. Like, because it's presented to us as that simple, right? Like,
Mhm.
you do the PHQ-9, for those listening, those are like basic screening questionnaire. You do the PHQ-9, do the GAD-7, you medicate, you check in 30 days, you titrate, and then you check in 60 days and you continue, which God bless, it works for some people, but I'm laughing because obviously it's so complex. It's the same thing people tell me, like, they don't ask it this way, but they're basically asking, how do I achieve health? And the
Mhm.
answer is, it depends. Like, each person's different. What supplement should I take? I have no idea. I don't know anything
Yeah.
about you yet. Like, it's so personalized. It's so personalized, and which complicates things, right? Because evidence-based medicine doesn't work on customization, right? Evidence-based medicine, conventional medicine, it can't function if we're customizing everything. So it really is, it's confounding to ask people to practice this way.
It's helpful to ask people to know their own health and to advocate for your own health, right? Because like how it is when you're in functional medicine, so you're like more private pay, but like the most clinicians, they have like what 15, 20 minutes. Excuse me. So like it's important for you to know your own science. So when you go to your doctor, you say, like I know my psychological history, I have a history of childhood trauma, so I tend to eat a lot when I'm stressed. And also my body is gonna be metabolically different because, people who have a history of trauma, there's a correlation between that and obesity, right? And so it's like, really, I want to put the knowledge and the tools into people's hands so that when they go to their clinicians, they can advocate for themselves, right?
Love
Because
it.
you know how it is. It's like 15, 20 minutes here and there. The
You're
doctor ain't
out.
trying to hear that.
They're not trying to hear your whole life. Do not come there with a I speak about medical gaslighting, and it's like, it's really about like using the system for the tools that it has, and then moving on to other
Yeah,
providers and practitioners. Do you treat patients at all, or are you just doing
I
studies?
do.
You do?
I have a private practice where I see patients with therapy and medication management, but I haven't taken new patients since 2019. I was booked even before the pandemic. So like that's why I did this book because it's like, well, in some parts of America, there's like one psychiatrist for every 30,000
Yeah.
people.
Yeah.
And when I started posting about my research on social media, I just inundated. So I was like, there's
Yeah.
got to be a way. First, I started a podcast and I was like, maybe long form is the way. But then it was like, no, that wasn't enough. And I'm like, okay, well, maybe a book that has like basic tools in it that I use every day for my clients and that I learned, maybe making that more accessible and democratizing that will help people to figure out what it is they need.
I love that so much. I'm on the same path. I stopped seeing patients. It got really, as I started getting better at my craft, I also got more and more complex patients.
Mhm.
And the one-on-one, it's impossible. Like you can't help enough people. So I also just, democratize information. I do these podcasts. I'm writing my second book, but you're right, just to disseminate the information so that people can learn about themselves and really just, keep questioning.
Mhm.
Keep questioning, but also question yourself. If everything's great, you should question that too.
Yeah.
That's so
No,
interesting.
it's very important. I love my patients. The patients I've had have been in my practice for years, and then my research practice is a team, so that's easier. But yeah, I stopped taking new patients in 2019 because it's like, and every person I refer to, they're like, we're booked. So this is a problem. If we
Oh,
wait for
mental
people to
health is a
break
huge
down,
mental health is
huge.
you can't, there's nowhere to send.
Yeah, if we wait for them to break down, then we're gonna have a queue of people who are like, you know, no longer functioning. But then there's also the line behind them, the people who are in line with the symptoms, waiting to no
Yes.
longer function.
Yes.
So we have to prevent this. We shouldn't
Yeah.
be waiting until they break down.
And then God forbid you have a language barrier or need a specific community.
Yeah.
Forget it. You're not getting access at all. It's the same with health too. I mean, we literally are waiting for people to break down
Yeah.
in health so that when
Yeah.
we give you medication, and then there's a line of people who are pre the disease,
Mhm.
and then like it's just yeah, the same line. It's the same
Yeah.
line of people. That's a very interesting visual that you put in. So that you can, it's like this never ending flow of humans that are in distress. I am grateful for social media. I know there's a lot of downside to it, but when I first started social media, to your point, I suddenly had people who were like living in trailer parks who were like, I didn't know. Like, I didn't know that eating Fruit Loops and Dr. Pepper in the morning was bad.
Hmm.
Like, seriously. And I remember talking to this one woman, I'm like, what do you eat for breakfast? And I was like, no, we can't. And she's
No.
like, well, what do you mean? And being able to give people information that way is great. I know there's overwhelm and I know there's all different sources and kind of have to do research, but it's important to do this. All right, what else do you want to tell our shared audience?
Well, in my book, I have a methodology based on evidence-based medicine, and it's the 5 V's. And I use five because most of us have 5 fingers. But
Like,
what I say is that, like, joy is in your hand. We're built with the DNA for joy.
aw,
And using the 5 V's, like validation, accept how you feel, no matter if it's positive or negative, venting, express how you feel. And it could be by writing or singing or praying or crying, however it is, get it out. Third is values. These are things that are with price, that are not with price tags, but things that are priceless, things that give you meaning and purpose every day. Tap into those. Vitals, you only get one body and brain. And I put a whole bunch of, tools in there to take care of that, including, getting away from toxic relationships. And then the fifth is vision, how to plan joy and to stay on the course. And I say like do one or two, tap into one or two every day. Don't try to do all five. It's just too much. But
the high performers are going,
right, yeah. But if you could tap into like those points of joy and with the goal of becoming happier versus being happy, right? You're
I love
increasing the
that.
points of joy, then you should be happier. The goal isn't happy because happy is an idea, but joy and
Happier.
becoming happier, that's the experience.
I love that so much. Happier. Oh my God. Okay, so this book is out.
It's out in April, so,
It's out in April. Okay,
April 8th, and you could
okay.
buy it everywhere. It's sold wherever books are sold.
It's amazing. Okay, oh my God, I have a million more questions, but I think I should probably let you get your time back. This has been so eye-opening. I've learned so much today. I love this podcast. I get to meet the most amazing humans. I can't thank you enough for teaching us all of these things.
Thank you so much for having me, and you can find me everywhere, Dr. Judith Joseph on all the socials, and I can't wait for your listeners to read the book and to, you know, be a human being instead of a human doing
Oh
again.
my God, I love that. I am going to read the book as well. I can't wait.
Thank you.
Of course, of course. Thank you so much for being here.
Thank you.
Thank you for tuning into the Medical Disruptor. If today's conversation resonated with you and you're ready to dig deeper, you can start with my book, which is on my website, drafratlamandre.com/book, or there's also a whole bunch of free videos there if you want to check that out. If you're interested in working with me one-on-one, please apply to my waiting list. If you're a nurse practitioner looking for courses to level up your clinical confidence, visit my website at egprep.com. Whoever you are, wherever you are, don't forget to subscribe, share this episode, and leave a review. It helps us reach more disruptors like you. Until next time, keep questioning, keep learning, and keep disrupting.